very well aware of, but it's Ben Meadly. So Ben Meadly is a senior flight MICA paramedic, mobile intensive care paramedic from Australia, from Victoria Ambulance Service. He's got 24 years experience. He's also a Monash University senior lecturer, and he's just recently got his PhD. So now it's Dr. Ben Meadly. Ben also writes clinical guidelines for Ambulance Victoria and was really starting to make quite an impression on the international stage as being a paramedic leader. And we're tremendously proud to have him on today. So over to you, Ben. Thank you for joining us.
Thanks very much, Christian. Hopefully I can make my screen work. Somebody please put in the chat box if it doesn't work. But thank you again for having me. And it's a pleasure to be here from Australia, where it's in the southern states at least. It's about just after 6 a.m. But good evening to everywhere else, and afternoon to some of you. Thanks for having me. I'm here to talk about our experience here in Victoria with critical care paramedicine, where we do have a fairly long history of this level of practice. And in fact, just 2 years ago, celebrated 50 years of the MICA system, or Mobile Intensive Care Ambulance System, here in Australia. So for me, my role, thanks Christian for the intro, I'm very lucky to have had a long career, and most of my career now has been as a critical care paramedic, and with the majority of that time working in the HEMS in Victoria. And just over the last 2 years, I've spent a bit of time seconded to Monash University to teach and research in the postgraduate programs and complete my own research. And then over the last year, work in translating some of those research skills into the critical care environment. And I'm very fortunate to be working in a role as a process or project improvement lead with Ambulance Victoria, in a role dedicated to the mobile intensive care ambulance system, where we get to take the evidence, we take current practice and hopefully evolve it for the benefit of our patients and our staff. For those of you who are not familiar with Australia, it's a very big country with a population of around about 26 million people and an area of 7.7 million square kilometres. And the state that I live and work in is Victoria, in the blue there at the southern tip of the Australian mainland. We do have one more part of a very important part of Australia to the south, that's slightly separated, Tasmania at the bottom there, but for the mainland, we're right at the bottom, and I'm coming to you from the bottom tip of the bottom. So we are one of the smallest states in Australia, but it's still a very big state in an area in raw terms. And we can see that, I'll just move my little cameras across so I can make the comparison. The service is a single statewide ambulance service that covers the entirety of the 222 or so square kilometres, with a population of about 6.7 million, but about 5 million of those people live in Melbourne. So the rest of the population is scattered across the far reaches of the state. So we have a very far-reaching need to service the community. And as a comparison for England, Victoria is about the size of England in its own right. And I've got a couple of other examples there, as you can see: Italy, Ireland, and California, the comparisons. So our HEMS in particular is scattered across the state there, as you can see, and 2 of our HEMS are located in the Melbourne metropolitan area. But in Ambulance Victoria, we don't respond into inner metropolitan areas with HEMS. We only respond outside the urban ring, with the odd occasional response inside that area. Just moving on a little bit, of course, we understand that the role of the critical care paramedic across the world is quite diverse, with a range of responsibilities. And we're going to hear from some great speakers later on from around the world to see the critical care evolution, if you like, for the paramedic specifically into hospital and other arenas. For the model in Australia predominantly, and certainly in Victoria, the critical care paramedic still predominantly, almost exclusively, practices in the out-of-hospital environment. So the responsibilities of critical care paramedics in Victoria, Australia, are to function in the areas of roadside motor vehicle accident rescue, for example. The helicopters are staffed by MICA paramedics who perform search and rescue roles on top of their clinical role. And one of the big components that has evolved is a long distance, complex intensive care or critical care retrieval is an important part of both ground-based critical care practice and also the helicopter-based critical care practice as part of our service. Now, of course, I haven't shown the less glamorous side of critical care practice in these images because, of course, the vast majority of the work we do is medical and or cardiac work rather than necessarily the type of work I show you on the screen. And this is an area where I guess our service has evolved to practice at what I would say is a highly functional and I guess governable and auditable level of practice is in those medical and cardiac patients, which actually speaks to the roots of the MICA service. The practice platforms that we see, we generally have a double crewed MICA ambulance, if you like. So 2 paramedics who are critical care paramedics working together on an ambulance is the predominant model. And that is across the metropolitan area, and 4 of the larger regional centres in Victoria also use that model. Now, those sites are supplemented then by single MICA paramedics working in a sedan type vehicle or SUV type vehicle, but they are generally around or near the 2 crewed ambulance vehicles, not in all circumstances, but for the most part. In the HEMS, we find a single MICA paramedic is the current model, and they work in conjunction with a crew officer who is trained to the level of EMT to be able to provide medical support, but also provides aviation support to the pilots. As I mentioned, we recently celebrated 50 years of mobile intensive care ambulance in Australia. A bit of a history lesson here across the time span. So back in 1971, the government of Victoria at the time had a report developed that looked at this increasing road accident death rate at the time. So high, no seatbelts, of course, and drink driving was normal practice, if that's the word. And unfortunately, the road toll was quite high. So at the time, the government and the health department decided to work out whether or not it was possible to provide some of the advanced interventions that were provided in hospital out in the field. And they commenced the trial at one of the very large hospitals in Melbourne that crewed an ambulance with a registrar, surgical registrar from the hospital, with an ambulance officer at the time. And in 1971, that underwent a 3-month trial, but it wasn't long before that was changed or taken on more permanently with the doctor and the paramedic. The doctor was on call from the hospital, but in 1973, it was determined that at that particular juncture, that the surgical registrar was better placed in the hospital, and that the single paramedic or ambulance officer working with the doctor during that time had demonstrated sufficient skill to be able to practice with another paramedic rather than a doctor. And as time went on, that was supported by formalized protocols. And after the initial training occurred within that hospital environment, the ambulance service took over its own training portfolio in 1976 when I was born, and then commenced training the paramedics in conjunction with the hospital. And Victoria was one of the first places in the world to have a university level accreditation for ambulance officers and paramedics. And a certificate level accreditation was awarded via the Royal Melbourne Institute of Technology, which is one of our leading universities in Victoria. In 1986, we commenced our first HEMS operations full-time, and that was staffed by a single MICA paramedic at that time, and remains the staffing model today, although that is in a process of evolution. And then after a period of time where historically registered nurses had staffed our fixed-wing aircraft, that they were replaced by paramedics, MICA paramedics initially, and today now a combined MICA and advanced life support paramedic staffing of all of our fixed-wing aircraft. In the early 90s, senior MICA staff were were transitioning to a role called a clinical support officer role, which remains today, where senior MICA paramedics provide junior staff with in-field training and support, as well as assessment, governance and audit roles. And also they play a role in our communication centres in some instance. And at that time, the major regional centres developed their MICA programs as well, which remain today. And the workforce doubled over the next couple of years, and to the point where in the late 90s, when I started my practice, as I became a paramedic, the first major clinical trial that Ambulance Victoria was part of had commenced. And that was a trial I'll talk about later, but the hypertonic saline in head injury trial commenced in 1988. University postgraduate qualifications in 1999. Paramedic RSI, paramedic-led RSI commenced in 1999 through to 2000 with some support from the Maryland State Police HEMS program, which we translated a lot of their practice over to the HEMS initially. And then the only ever randomized controlled trial of RSI versus no RSI in severe traumatic brain injury commenced in 2004. And ran through to 2008, and many will be familiar with that trial. And there's been almost limitless ongoing RCTs or trials at any given time, which I'll speak to later, that have continued on. And they include Rinse, Rich, Polar, Avoid, Patch, and then linking in the late 2010s with blood product carriage on all of our aircraft, surgical thoracostomy, and point of care ultrasound development, now to the point of registration, formalised ongoing credentialing, which I'll speak to. And then we look to the evolution currently for our road-based practice, now evolving in a similar line with our air-based practice. What does it take to become a MICA paramedic at Ambulance Victoria? Well, for most people around that are on the symposium today, a bachelor's degree is the minimum level qualification for paramedics, as it is in Australasia, so Australia and New Zealand, and understandably also the UK. And of course, there are many honours programs. If paramedics before or during their first year of practice want to complete an honours program, that is offered at a number of Australian universities, including Monash. The intern program at most ambulance services, but including Ambulance Victoria, is 12 months or so. We then require a further 12-month consolidation period where the paramedic is called an AP12 or ambulance paramedic, 12 months post-qualification, followed by their period as a qualified ambulance paramedic. Generally, we ask those who are wanting to apply for the MICA program to have at least 2 years post-qualification experience before they would apply for the graduate diploma, which is part of an overall master's program. And that at this time is partially funded by Ambulance Victoria for some scholarship incidences. We see that program taking about 2.5 years part-time, and then students have the option to pay their way to completion of an master's, which is only another 4 units once the graduate diploma is completed. And we see quite a few people electing to continue on to masters, which is great to build a master's workforce for our critical care people. Once the completion of the graduate diploma is done, the paramedics move out on to work clinically with a clinical instructor as an intensive care or critical care paramedic intern for around about 2 years. And then they sit a final examination, followed by a further consolidation year, similar to when they were ambulance paramedics and completing their initial graduate program. And during that time, it is supervised practice, and there's no autonomous drug or medication facilitated intubation, for example, and a number of other procedures require supervision. Once that period is complete, so you're kind of looking somewhere between 5 and 8 years down the track from the commencement of the bachelor's degree, then working as a MICA paramedic, you can move into other roles such as clinical education and instruction, communications, clinical support. But moving to the next level of critical care specific practice it's the graduate certificate in aeromedical retrieval at Monash, followed by, and that's a year, followed by another IC intensive care flight paramedic intern program for 6 months or more sometimes, at which point you would become a qualified MICA paramedic. But that is a highly selective program and is not a natural evolution per se. So what are the core functions of MICA practice that have been really important in building our system? Research is absolutely integral to our ability to roll out or develop or deploy skill sets in particular that we firmly believe must be embedded in research and evidence-based. We have a very robust and lengthy research program with a dedicated centre for research and evaluation, strong collaboration with universities, and well-established registries and epistries to provide the evidence for our practice. We also have robust governance and audit that makes use of a range of different technological initiatives, is engaging once again of the front line. All paramedics know that they are heavily audited. We have a degree of automation about how we audit as well, aligning with our national standards of practice. Our professional development is evolving. There's mandatory learning, of course, but we're finding our ability to provide novel ways of credentialing our staff, especially in the post-COVID era. And of course, a strong link to solid foundations in undergraduate and postgraduate education programs that are led by subject matter experts with a strong link to the tertiary sector. And we would say that they are the core components of what makes our service sustainable over those 50 years and continuing to evolve. How do we credential our MICA paramedics specifically? There's a minimum registration requirement of 30 hours of professional development, and most paramedics in Australasia would cover that with their in-house learning, if you like. But of course, events like this contribute to CPD or professional development hours as well. That is mandated by Ambulance Victoria. Also mandated by Ambulance Victoria is continuing education days, and they are up to 5 per year, and they've had to go a bit remote, obviously, over the last few years. But in general, they were face-to-face days, and they are for all paramedics at Ambulance Victoria. And there are additional MICA-specific days, and specifically, I can reference the move recently to a new ventilator for our ground-based MICA paramedics, the Zoll Z-Vent, and that was a comprehensive day-long program that also included the move from a proprietary device cricothyroidotomy procedure to the more recognised scalpel finger bougie procedure. So that MICA-specific day encompassed those 2 new skills. Additionally, MICA paramedics are required to complete a mandated practice skill set. For our advanced life support paramedics, they complete 11 to 12 modules online every year, in addition to all of their registration requirements, and in addition to the continuing education requirement, face-to-face or even online programs for Ambulance Victoria that is in addition to registration. For our ground-based mobile intensive care ambulance paramedics, there are 19 modules that are required to be completed. And for our flight paramedics, the MICA flight paramedics working at air ambulance, 26 modules, so quite a significant credentialing burden each year, and they must be completed within the credentialing year. This speaks to a really important part of the professional evolution to ensure that when we complete these programs, and here's a couple of examples of these online learning programs that form the mandated practice skill set, we have point of care ultrasound, arterial line, rapid sequence intubation, and finger thoracostomy as an example of the programs that ensure our staff are adequately credentialed to perform their skill set, especially for those what we would call halo skills or high acuity, low occurrence skills. From an audit point of view and governance, for a MICA paramedic, every single patient care record would be reviewed formally, or I guess, I'll say informally. Every patient care record would be reviewed informally at the team level. So the team manager or the paramedic educator at each of the locations would provide 100% audit of the patient care records. In addition, we have dedicated cardiac arrests and STEMI audits for those patients with suspected STEMI or OMI, if you want to call it that these days in the more contemporary vernacular. And they align with our very large registries, the VACAR, Victorian Ambulance Cardiac Arrest Research, the largest cardiac arrest registry in the world, as well as the VASCI registry, the Victorian Ambulance STEMI Quality Initiative, where all cases are audited for those two case types. In addition, the Department of Health in Victoria uses a software program called Riskman, and that allows all paramedics, anyone, managers or frontline paramedics, doesn't matter who you are, to report clinical incidents or near misses into a easily accessed mobile-based or desktop-based software platform. And every incident is reviewed daily by a dedicated team each morning, or each weekday morning anyway. And then immediate action may occur, or if only minor concerns, then followed up in due course. Similarly, there is a mandatory audit that we've historically called our audit for our halo skills, or the high acuity, low acuity skills. So there's a predefined mandatory separate audit for all high risk skills such as intubation and cricothyroidotomy. And in fact, every cricothyroidotomy alerts an immediate notification to our medical director for real-time review with the crew. And other things that are reviewed are RSI, and that has an additional quarterly panel review of subject matter experts who review every single case. And we would do 900 to 1,100 RSIs in our service per year. Pleural decompression via surgical or needle method, depending on your skill set, is also reviewed independently and then by a panel, and as is mechanical ventilation and arterial access, which is only within the skill set of the flight group at the moment. Again, it's drilling down to a little bit more of the specifics around our research. We have a dedicated Centre for Research and Evaluation, which at the moment has a director who is a paramedic by trade, and also is a very senior research fellow with the National Heart Foundation, and still works clinically a number of days a fortnight as well. So we're very fortunate to have a very an extensive research program with very robust research governance. So we don't just allow any research project to occur. It is filtered mainly to balance the burden on the paramedics. So we don't ask them to do too much. We have very close collaborations with universities, and in particular with Monash, to build and maintain the registries. And we have about 10 operational staff across our 5,000 paramedics with PhDs, and they all work clinically. I've been fortunate to be part of a number of clinical trials during my time at Ambulance Victoria. All of these I've been a frontline participant in. A couple of them I've been part of the research team, and I won't go through all of them in particular, but CHEER is one of the largest out-of-hospital ECMO trials that has historically been done. AVOID was the major trial that had the removal of oxygen for STEMI. Rinse and Rich basically put cooling in cardiac arrest to bed, that it's not necessarily beneficial to patients with therapeutic hypothermia and cardiac arrest. The list goes on. The RSI trial as well is in there. And additionally, the PATCH trial, which looks at tranexamic acid, is just about to be published. So the first pre-hospital randomized control trial of tranexamic acid versus placebo. So keep an eye out for that one very, very soon. So what are our major challenges, just as I finish up? Getting our dispatch accuracy right so that we're sending our critical care skill set to the right jobs is a challenge. Ongoing credentialing for very advanced skills, halo skills, where you very rarely see these cases, but are asked to perform at a high level with a more complex procedure, is a challenging thing to do, to expose staff and credential staff. Our workload is very high, so it's hard to maintain that. Everyone's suffering the same problem, which translates to challenges around work satisfaction, selection and recruitment, and burnout. We also need to plan and give a better career trajectory for our staff, perhaps giving them a more realistic expectation of what they're in for in this role as a critical care paramedic. And the path forward for us is to keep asking the questions we've always asked about how we can improve and what we've learned, and start looking at novel solutions to the problems that we face, using technology to be adaptable and respond to change promptly. We've seen that, of course, over the last couple of years, that prompt agility, I guess you'd say, or adaptability. And we need to continue our professional evolution, but we also need to recognize our limitations and be honest about what we can achieve. There are things we can do in the out-of-hospital environment as critical care paramedics. There are things that are not useful, and we need to use the evidence to support that, to build our professional development and capacity. We need to move into a phase now of accrediting our CCP academic programs. At the moment in Australia, you just recognise registration as a paramedic, not as a specialist paramedic. And we need to look to enhance our workload management and challenge those historical norms. If you're interested in the Ambulance Victoria guidelines, you can just Google Ambulance Victoria guidelines and it'll come up. Otherwise, there's a QR code there for you. But all of our guidelines for our intensive care skill set and all of our skill sets are freely available and updated regularly. And for the paramedics who work for AV, very regularly, you would suggest. For Monash University, we have a range of postgraduate critical care programs, and you can just Google Monash Paramedicine to get more information, or you can use the QR code link there to find out a bit more. I'm contactable via this QR link here, or via the email, or via a small website I have that shows some of my research. If you're interested in talking about research programs and collaboration, always open to look at further evolving critical care paramedics across the world. Thank you very much for your time. That's a photo that Christian took of me hanging out of a helicopter when he came and spent some time with us. Thanks, Christian, for your friendship, your professionalism, your time with us in Australia and hosting this event. Thanks, everyone.
Hi, Ben. I'm going to jump on as Christian's in his shed. Thanks ever so much for that. It was really fascinating and great to... It's morning over there, if I'm right, isn't it?
It is. It is.
A couple of questions that have just fired straight through. Can, sort of, as I know, frontline paramedics, can they intubate?
Say the question again.
So your roadside paramedics, can they intubate?
No, only MICA paramedics. Yeah.
Okay, and the yearly credentialing modules for MICAs, how can they be viewed?
They are not public, but I'd be happy to share if people would like to look. There's no secret about them. They're just located on our internal platform. So I'm more than happy to share some of those credentialing that information. I was lucky to be involved in the development, so happy to share. But yeah, they're not publicly available.
No, that's cool. I was thinking that what we'll do in the new year, we'll edit all the videos, trim bits out and things. But what we'll probably do is I'll collate all the information, including those QR codes, Ben, and where people can find extra information. I'll send these out. We'll get them sent out to college in the new year. And then just one final question is coming from New Zealand. Can critical care paramedics with yourself, do they self-dispatch?
Effectively, yes, but that would be via consultation. So we have a senior MICA paramedic in the communications room 24/7, and so they would ask to be dispatched, and just so that somebody's across it. But effectively, yes. But I would say even though I kind of had a little bit of a dig about getting the jobs right, when we get the sick jobs right, I would say that our dispatch grid and system gets the sick ones right. It's the not so sick ones that we tend to have the hit rate or the miss rate. Sorry. So yeah, for the most part, we tend to get those right. But effectively, the answer to the question is theoretically yes, but it requires just a bit of communications to make that happen. We don't generally have people roving around self-dispatching to jobs, which is a bit different to what Matt will talk about in a second.
Brilliant. Well, listen, Ben, I'm going to thank you ever so much for your time there. Again, thank you ever so much. Okay, we'll get information sent out, but thank you for your time, Ben.
No worries.
So we've got the Q&A the Q&A function, which is coming through. I'm answering some questions that are coming in. There's also some 3 small dots that you can click on and go through to the chat function as well, which we're monitoring. So without further ado, I'll move on to Matt.